Welcome to Bringing Life to Scholarship. Bringing Life to Scholarship is a symposium series sponsored by the Herbert H. and Grace A. Dow College of Health Professions here at Central Michigan University. I'm Dr. Peter Lubert, and I'll be moderating today's presentation. If you're watching this presentation live on the web, you can email questions at any time during the presentation by clicking the Ask button. This and all previous presentations are archived and available online at www.chp.cmich.edu. Today's presentation is by Dr. Elizabeth Mostrom. Dr. Mostrom is Professor and Director of Clinical Education in the Doctor of Physical Therapy program here at Central Michigan University. She is former Editor-in-Chief of the Journal of Physical Therapy Education and is recognized nationally for her expertise and contributions to clinical education and physical therapy. She's also a recipient of the Excellence in Teaching Award here at CMU and of the Richard E. Darnell Research Award from the Michigan Physical Therapy Association. Dr. Mostrom's areas of research interest are in qualitative research, student and professional learning, and the development of clinical expertise. Today's presentation will be Exploring Expertise in Clinical Education, the voice of outstanding physical therapy instructors and their students. Dr. Mostrom.
Thank you, Peter. I do apologize. I'm coming off a little bit of a cold, so I'm going to have to sip my water every so often as we get started. So today I am sharing with you some findings from a qualitative investigation that I've undertaken to describe and understand expertise and mastery in clinical education or clinical teaching in physical therapy, and concurrently to explore the learning of students as they work with exceptional clinical teachers. And presenting on this topic today on a day when we honor outstanding clinical teachers is somewhat humbling. Because there are probably few findings that I will share today that are news to those individuals who are exceptional teachers or the students who've had the opportunity to work with those kinds of teachers. But even so, the findings that I present today have not often been described in the literature, especially based on qualitative inquiry. A lot of the literature that's out there about characteristics, attributes, teaching behaviors of exceptional clinical teachers is survey-based literature. So I would also like to recognize some of the graduate students who have worked with me on one arm of this study, and that's the collection and analysis of student data. And they are several of our DPT students from the past several years, and their names are shown here, and I appreciate their assistance with the study and their interest in this area. So just a brief bit of background. I hope that we will all agree that clinical education is of critical importance in the shaping and practice of future physical therapists and healthcare professionals in general. For those of you, I know several of you are not physical therapists, but I hope that my findings speak to you as well. In fact, in physical therapy education programs in the United States, approximately 40% of the total contact hours in the professional curriculum of what is evaluated as an average physical therapy program occur in clinical education. So that's a huge component of the overall professional curriculum. Even so, the clinical curriculum and experiences are sometimes still viewed as sort of supplementary versus integral to the total academic and didactic curriculum in terms of preparing students for entry into the field. In spite of the importance of clinical education, anecdotal and research evidence suggests a wide variation in student experiences with clinical instructors. Some have tremendously positive experiences, and some have experiences that they would describe as detrimental to their learning. For some students, it can feel like, as the metaphors that I've shown here, and I hope you can see those, climbing an ice wall from the Upper Peninsula, or diving into a volcanic cauldron on the North Island of New Zealand. But Unfortunately, I found that many of the students that have less than positive experiences in clinical education often recast them into positives insofar as they report that they learn what they don't want to be as a physical therapist. However, that's hardly the legacy that, as an instructor, you might want to leave with your students. But of greatest interest to me for the current study is the profound and positive impact on learning and professional development that students who have worked with exceptional CIs report. Here I should note that in physical therapy education, we refer to clinical preceptors or supervisors as clinical instructors, hence the CI label. I'm afraid that I'm going to use that a lot in the course of this talk, but anytime that I'm doing that, I'm talking about clinical teachers in physical therapy or other fields. So questions that emerge out of these observations are, what can we learn from CIs who have been identified as excellent teachers? How can we best understand their personal and professional developmental trajectories, their beliefs about student learning and clinical teaching, and their actual practices as a clinical instructor? And how might we use such knowledge for CI training and the enhancement of future learning experiences for our students? Other questions draw our attention to the students' perceptions, experiences, and learning as they work alongside exceptional clinical instructors. And some of those questions are shown in this slide. So some of the broad purposes of the investigation I'm reporting on today are shown in this slide: to explore the professional and personal development of PTs who've been recognized as outstanding clinical instructors, to elucidate the nature and sources of their beliefs about teaching and learning in clinical settings, and to describe the characteristics, attributes, and instructional practices of exceptional CIs from the perspective of those instructors as well as their students. Furthermore, the purpose is to explore the nature of clinical learning experiences for these students and try to get a clearer sense of what it is they are learning and how they are learning in clinical environments. And finally, to generate grounded theory about clinical instructor expertise and student learning with excellent teachers in the same way that myself and other colleagues have done through previous explorations of clinician mastery in physical therapy practice. So how to go about such broad aims? And here's our Dr. Lubert. What should be clear is that my focus in these investigations is on the scholarship of teaching and learning, as first described by Ernest Boyer in the early 1990s, and later elaborated by Lee Schulman and colleagues at the Carnegie Foundation for the Advancement of Teaching. Furthermore, when we consider the potential methods for investigating teaching and learning, there are many. And for this investigation, we have used primarily qualitative approaches to inquiry. So now I'll talk a little bit about the study design. This study is a multi-phase, multi-year investigation employing primarily ethnographic and microethnographic methods to gain a comprehensive and detailed understanding of mastery in clinical instruction. We use interviews of clinical instructors, students, and ultimately patients will be involved. Observational data will be collected in clinical sites during learning experiences. Social linguistic or microethnographic analysis of CI student and CI student patient interactions will be completed, and artifacts related to the experience will be reviewed. So you can see that multiple sources of data are being sought to triangulate, but perhaps more importantly, multiple sources and methods are employed, since mastery in clinical instruction can hardly reside solely in the teacher. Clinical learning experiences, as you all know, are highly relational. They are contextualized and embedded in the culture of the clinical site, the culture and norms of physical therapy and health professional education in the United States, and the culture of healthcare in our society. Print on this slide is a little odd, but some of the elements of clinical education are shown in this slide, which draws on the work several decades ago, as a matter of fact, of Rosemary Scully and earlier educational researcher Schwab. As I just mentioned, all of these components are nested in several larger cultural frames. And the study I'm discussing today has taken as its starting point the interaction between teacher and learner, which we find is a reciprocal relationship in many ways. So I'm reporting on phase 1 of the study and part of phase 2. I'm presenting some of the data from the CI, or actually all of the data from the CI arm of the study and some of the data from the student interviews. We've also begun analysis of matched pair CI and student data, but I won't be reporting on that today in the interests of time. In phase 4 of the study, we will select a purposive subsample from the existing sample and move to collection and analysis of observational and sociolinguistic data during clinical education experiences. And it's my hope that that last phase, like the work of Jensen, Hack, Guire, and Shepard in physical therapy clinician mastery, will become a multi-investigator and multi-site inquiry. So the sampling frame for phase 1 of the investigation consists of recipients of the Michigan Physical Therapy Association Special Interest Group for Clinical Education's Outstanding Clinical Educator Award. So that's a big mouthful. I had to get it all out there because that's the group that gives the award. That award has been given since 1992. So our frame was through 92 to 2005. The process for nomination and selection for this annual award is well developed, and it involves student nominations and evaluation forms, peer references, and committee review and selection. And once this potential purposive sample was identified, further inclusion criteria were that recipients had been involved in clinical education as a CI or a center coordinator of clinical education during the past 5 years, and that they consented to participate in the study. And that I was able to find them, which I wasn't, of course, for all of them. The instruments and methods used in the study included demographic questionnaire, a resume sort, which is a method used to engage the participant in evaluation of important events or activities in their professional development, and a semi-structured interview, which included a description of an exemplar. And I'll talk in a moment about what an exemplar is, but for those of you familiar with critical incident technique, it bears a resemblance to that. The interview foci and questions for CIs are listed on this slide. We completed a review of the resume sort. The participant was asked to provide a detailed exemplar, a detailed description of an exemplar, and a series of other professional development and practice questions followed that are shown in that slide. And I will touch on each of those areas when I present the findings from the interviews. For the student interviews, we sought out individuals who had nominated the recipients of the Outstanding CI Award in the same time period, were still practicing, and consented to participate. And I should say, really, graduate interviews. At the time that they nominated these CIs for the award, they were, of course, students. By the time we interviewed them, they were graduates of physical therapy educational programs. But I'm going to continue to refer to them to students because we're talking about their student experience. Now, these potential participants have been even more challenging to locate, and the actual sample, I'm sure, will be considerably smaller than the sampling frame. The instruments and methods that we've used for data collection from students are similar to those for CIs. Save the resume sort. And many, though not all, of the questions in the interview are parallel construction to those asked of the CIs, and that facilitates the matched pair analysis of CI and student data. So thus the primary areas addressed in the student interviews are shown on this slide. I think you can probably see the linkages to the CI questions, and again, I'll talk to each one of these as we go through the findings for some of this. So data analysis. All interviews were audio taped and transcribed verbatim. Analysis of the demographic questionnaire involved the generation of descriptive statistics and frequencies to provide an overall description of who our participants were, and also practice settings in which they were. I treated the interview data as a multiple case study design with cross-case analysis. So codes, categories, and themes were identified using a constant comparative approach, which is frequently used in ethnographic inquiry and has also been described by Glaser and Strauss for use in grounded theory studies. So the sample description is provided in these next slides. 17 CI interviews have been completed, and at this point I feel the data set is saturated. This means that in the last few interviews that were conducted, there were no new themes, patterns, codes, or discrepant cases appearing in the data, which suggests that we've sort of reached saturation. For those of you that aren't familiar with qualitative inquiry, saturation could be considered analogous to power in quantitative methods. So it means that we have a sufficient sample to make some assertions and feel comfortable in those assertions. Now, when you look at this data, you can see that there's a fairly even gender mix. The mean age is 39 years, and the mean number of years as a PT is 15, and 11 of those 17 had more than 10 years of experience as a physical therapist. The mean number of years as a clinical instructor was 12, but 9 had 11 or more years as a CI. A glance at the ranges also suggests that there was at least one new PT and CI, which there were in fact two with less than 5 years of experience as clinical instructors. Otherwise, this is really quite an experienced group of clinical instructors. And I don't want to diminish, however, the input and contributions of those that were younger CIs, because all insights from the participants were valuable. A little more about the CIs. Here you can see that they've worked with a very good number of students over the past 5 years. So a mean of 9.4. But 2 of the CIs in this sample had worked with about 20 students over the past 5 years. So they really like working with students, bless their hearts. So that was incredible to me. I think I just hit that mic. Now, most of these CIs entered the field with bachelor's degrees, and I think some of you know that there's been a changing entry-level degree in physical therapy over the past few decades. And the overwhelming majority, however, had pursued either clinical specialization and certification, post-professional degrees, and or clinical instructor credentialing, which is a professional development program available through the American Physical Therapist Association, and we have a trainer for the CI credentialing program here in the audience today. The students. So far we have 8 student participants. And the mean age of those participants is 27, with most of them falling in that 25 to 29 year window. They've worked as PTs between 1 to 8 years, but most were in the first 2 years of their career at the time of the interview. These students spent anywhere from 7 to 14 weeks completing clinical internships with the instructor that they nominated for the award. For the students, 6 of the participants were completing internships in hospital-based or affiliated clinics when they worked with the CI, and 2 were in private practices. They had mixed patient populations, as shown on this slide. And the 2 more experienced therapists have gone on to become CIs since graduation from PT school, though they all indicated that they were interested in doing that. Many of them were so early in their careers that they weren't ready yet to assume responsibility for student supervision. Okay, let's look at some of the findings. We'll look first at the clinical instructor findings. In the resume sort activity, the participants were asked to sort activities that were listed on their resume and then placed on little cards. It was sort of like a little game. And they had been cut up and placed on cards, and they had to sort these into stacks of activities or events that they felt were most influential, somewhat influential, or not very influential in their development and learning as a clinical instructor. And there were 6 main categories of activities that these fell out into, and those would be typical of what you might expect to see on a resume. So, what were some of the most important activities? Oh, that's interesting. These therapists highly valued their involvement in professional organizations and listed many of those activities as most influential in the development as a CI. All of them were APTA members, and most were involved in various components of the organization at the local, state, or national levels. And when I refer to APTA, I'm referring to the American Physical Therapy Association. Several were also members of other professional organizations. For instance, 3 of the people in this sample were also fellows of the American Academy of Orthopedic Manual Therapists. They all had a great deal of continuing education, and often there was overlap between the categories of continuing education and professional activity. That is, they served both of those purposes for these individuals. The great majority felt that their physical therapy entry-level preparation was influential. I was glad to hear that, including, importantly, exposure to academic and clinical faculty models, and we'll discuss that further. Most of them saw their PT preparation as the foundation on which they have built as a CI, and this was really served as the primary source of their identity as a physical therapist student. And so it was this physical therapy student identity, what they remembered from that experience, that was really, really important to them from their PT educational preparation. And they called on it frequently when they were describing their philosophy and their practices and beliefs about teaching and learning in the clinic. In the somewhat category, there were a variety of professional memberships and activities, continuing education and work experiences, and community services. All of those things were cited. All of the participants viewed their recognition with this award as somewhat important in the development of the CI. And they described it variously as an honor, a reinforcement, a validation, although several pointed out that it didn't or wouldn't really change what they do as a clinical teacher. And time really doesn't permit me to give you a lot of direct quotes today, but let me share this one. This is what one participant said. You try to do the best job that you can, but then when you get something like this, it's like, wow, I've been recognized for something I really like to do, and it makes you strive to do even better. Now on to the exemplars. An exemplar is a detailed description of a critical event, a defining moment, or a turning point in one's professional development. And for this sample, it was in their professional development as a clinical instructor. Description of exemplars as an interview strategy was used in Patricia Benner's studies of nursing expertise and also in Jensen et al. Studies of physical therapy expertise. The CIs were asked to identify 1 or 2 exemplars and urged to sort of tell me the story of that moment or try to replay the video of that moment for me. So by far the most frequently described exemplars were descriptions of these CIs' experience as PT students working with their previous CIs. And in roughly half of these cases they were positive experiences with the CI, and they now seek to emulate the characteristics and behaviors of that CI. In the other half, these were negative experiences, and they defined for them, quote, what they didn't want to become or be for other students. The other most frequent description was of their learning through doing, through their teaching experiences with students and reflection on those experiences. They often asked themselves what went well, what didn't, and why. And often such critical reflection occurred at the times that they were working with very difficult or challenging students. And in some cases, these were students who didn't succeed in passing the clinical internship. But noteworthy was that these CIs took seriously their responsibility to help those students succeed, and they examined not only the performance of the student in that regard, but also their own performance as a teacher. And so these reports are consistent with findings by David Irby, who studied medical education in depth. And he finds that good teachers often learn their craft through an apprenticeship of observation, of good and bad teaching, and reflection on their own teaching successes and failures. Some of the earlier findings forecast the findings that I'm reporting next. The CIs were asked to identify people versus events or activities who influenced their learning and development as a CI and describe how they influenced them. And responses were categorized as those that either fell into teachers and professional colleagues, students, or patients. In the category of teachers, 11 participants identified PT academic faculty members who served as professional role models for them. And these faculty members were almost universally described as shown in this slide, involved in professional organizations, education, and practice. The CIs perceived them as extremely dedicated to the profession and their students. They noted that they were knowledgeable and up to date, but they also challenged students to ask important why questions, to critically analyze what they were learning. One CI noted, quote, he modeled evidence-based practice long before it ever became cliche. And finally, many noted that these faculty members had positive and respectful interactions with students, and they felt recognized as a unique person in their encounters with them. Other influential people were the clinical instructors, as I suggested earlier. There were 11 descriptions of positive experiences with CIs in response to this question. And these CIs often were described as those that were very involved and in professional activities, as being patient with this person when they were a student, respectful and supportive of both students and patients, and being well-rounded. Now, 8 participants described negative experiences with CIs that included behaviors of not voicing expectations or being clear about what they were looking for from the student. One CI described it as it was a CIA kind of thing, you know, like sort of a furtive, what are you doing now? That felt very uncomfortable. They also described supervision at the shoulder through the entire experience, so there was never any release of supervision, public humiliation, and outright unethical behavior. So these negative experiences were turning points for these CIs because they said to themselves, as the quote on this slide shows, I would never ever be that way with my students. Other influential people, 11 identified other professional colleagues who they felt were role models and mentors in their development as both clinicians and clinical instructors. And as you might expect, and has been borne out in other literature and studies of expert clinicians and clinical teachers, the identity of clinician and the identity of clinical teachers are really tightly interwoven for these individuals. The typical characteristics of these role models and mentors are shown on this slide. And one person described her mentor as not an 8-to-5 PT and discussed how this mentor had influenced her to be a therapist who practices by the people and not by the numbers. Students were also influential for these clinical instructors. Most CIs report that they learned something from all of their students, and this included both very strong students and very difficult students, as I indicated earlier. One CI remarked on how the wide spectrum and diversity of students constantly requires him to reconfigure his approach according to each student. And in all cases, these CIs viewed the CI-student relationship as one of reciprocal teaching and learning, and often made that view explicit to the students right at the start of the experience. They frequently indicated that they were not the all-knowing or the all-wise one, and that they were looking for learning from the students as well as providing them with some teaching. Finally, influential people for these instructors included their patients. The CIs saw their relationship with patients as similar to that with students in some ways. That is, the relationship is one which involves reciprocal teaching and learning, partnering, and mutual respect and mutual responsibility. As one CI put it, as therapists we are teachers, and healing and learning are joint efforts. These CIs translate the lessons learned from their patients over the years into their encounters with students. And such lessons included the importance of using people-first language, of respectful interaction, of obtaining informed consent, being an active listener, and being patient. When I asked the CIs how they felt students learned best, their responses merged with another question about the type of environments that enhance learning in the clinic. The recurring themes are shown on this slide. It needs to be a comfortable, non-threatening environment where the student feels welcome and supported by the CI and the other staff, and where the student is invited to be a partner in decision making and designing the experience. Where the CI is accessible and not all-knowing. And as one CI stated, quote, "I let them know I'm not a know-it-all because I'm not. I want to make them feel it's okay to come and talk, that it's not a bother. That's why I'm here." And finally, several CIs believe that visual and kinesthetic experience combined with appropriate sequencing and pacing of activities during the experience were facilitators of student learning. The flip side of that question is, what do they feel impedes or constrains learning in clinical environments? And the descriptions tended to be on the other end of the continuum, as you might expect. Impediments or barriers to learning included, first and foremost, fear and discomfort. And sources of fear can be from the environment, from the CI themselves, from the staff, or the student. For example, fear of being wrong is often linked to perfectionism in the student, or fear of humiliation or public embarrassment would be linked to the behaviors of the clinical instructor in many cases. To avoid the latter of these, the CIs indicated they were very careful about how and when they asked questions of students. The answers to this question and the previous question really suggest that knowingly or unknowingly, these CIs were attentive to what Abraham Maslow's hierarchy of needs, insofar as they recognized that the students needed to feel safe, not fearful, as well as a member of the community, needed to have a sense of belonging, which they worked hard to create before they could increase their self-esteem and ultimately achieve self-actualization. The other things that they identified as impediments or constraints to learning were the realities of today's healthcare environment with respect to productivity demands, and also reimbursement issues in terms of what students may or may not do in the clinics. They certainly recognized that if there wasn't good pacing of activities, or if CIs weren't upfront with students about their expectations, or there's too little guidance or too much guidance or supervision, that those could be constraints. When asked about their philosophy of clinical teaching or the principles that guide their work with students, several themes emerged, and the most frequent are shown on this side. They really saw their role as being a guide and facilitator of learning and an advocate for the student. They also believed that they were partners in this learning endeavor, and that students could be an active and should be an active part of the team. And over again, these CIs expressed their belief that teaching is not telling or spoon feeding. Rather, their aims were to encourage self-discovery via thoughtful questions and reflection in and on experience, or as one put, to plant the seeds of lifelong learning. In short, they saw themselves primarily walking side by side with the students in this journey, and occasionally pulling them along to new insights, and other times giving them a little nudge towards self-revelation of these insights. When the CIs were asked what they actually do to try to enact their philosophy and act in accord with their beliefs about student learning, they described the following strategies. Engage in early activities to make the student feel welcome, and early on find out where they are, and that came over and over again. And that's what Scully and Shepard in studies many years ago referred to diagnosis of readiness, sort of knowing where the student is and starting from there. So that dynamic assessment is an ongoing activity for the CIs in this sample, and assists the CI student dyad in sort of mutual goal setting, activity planning, and pacing. And in this mutuality, then, the student sort of owns some of the responsibility for the experience as well. As one CI put it, I just like to let them be in the driver's seat a bit. They also sought to create opportunities for preparation when they knew something was coming up, so they'd get a chance. They knew a challenging patient was coming, and there would be the need to do specific evaluative techniques, then they would give them the opportunity to look those up, practice them with the CI, and then actually perform them either jointly or independently with the patient. The other thing that they sought to do was decrease anxiety, as I mentioned earlier. And as one CI noted, you can't mitigate all of it, anxiety, but you can take it down a notch. And finally, they sought to help the students find the answers within themselves. And that was by setting the stage for questioning, asking when questioning would be appropriate, and negotiating the how of questioning. When asked about moments of ethical distress encountered during their work with students, the CIs described situations that fell into 4 primary categories listed here. In the resource allocation category, examples were denial of services that were believed needed for patients, or billing for student time when they knew that the efficiency or skills of the student were not equal to those of the CI. There were struggles between patient autonomy and the PT's duty of beneficence that often centered around discharge decisions. Unfortunately, there were also several situations involving the observation of disrespectful interactions or suspected or actual negligence or abuse. And finally, there were instances of inappropriate use of support staff. And so in all of these cases, however, the CIs spent a lot of time discussing the situations with the students and often had them travel the path in terms of management of the situations of altruism, advocacy for the patient, integrity, and professional duty in response. And this particular question is really a research study in and of itself and fodder for a chapter that I have also written. The ideal student, who is this person according to these clinical instructors? And there was full consensus on the descriptions of an ideal student as shown on this slide. The ideal students, like these CIs, are enthusiastic and willing learners who take initiative, who assume responsibility and are self-motivated to advance their knowledge and skills. They're described as being socially capable and respectful in their interactions with patients, caregivers, and other staff. And finally, they take a genuine interest in their patients and have passion for what they do and are committed to their profession. Challenging students, who are these individuals? Well, the most challenging or difficult students were consistently identified as those with poor interactive skills, especially as conveyed by insensitive or inappropriate remarks to or about others. Also, those who felt they knew it all, quotes, were closed-minded or seemed to be, quote, just going through the motions. And these attitudes often translated into a perceived lack of commitment to learning and the observation that the student just wasn't putting in the expected time and effort to an experience that was requiring, when it was a difficult or challenging student, a huge amount of time from the clinical instructor. Furthermore, a lack of self-awareness and self-assessment were often part of this constellation of concerns. Collectively, these kinds of behaviors are what Wolf Burke has described as generic inabilities or bloopers in the physical therapy literature. And finally, some CIs did say that they had encountered some difficult students that simply didn't possess what they believed were the requisite skills and knowledge to make sense of their clinical experience. When I asked the CIs what they hoped the take-home message from their experiences with students would be for these students, the most frequent and almost universal refrain was never stop learning ever. Several of these CIs went on, however, to add that the engagement in this process of lifelong learning was not just for the purpose of the student's own advancement and development, but for the higher aim of bettering the care that they provide for their patients. This thought resonated with the take-home messages of being an advocate for the patient and treating each patient as an individual and teacher. In addition, many CIs hoped that students took the mantle of responsibility for passing on what they learn, not only to patients, but to other staff and future students. And as one CI put it, just don't break the chain. When asked what their advice for novice clinical instructors would be, these CIs urged new clinical teachers to be self-aware and true to themselves, to not try to know it all, and to be open and honest about their strengths and limitations with the students that they work with. Not to try to create mini-me's, okay? They encouraged CIs to revisit and reflect on their own experience as students so they were closer to walking in their shoes. And they wanted to remind the CIs that this was a learning experience for them, and that treating it as a learning experience rather than a performance of perfection when they're working with students would advance everybody's experience. And they wanted them to know that they're not alone and that there are a lot of resources, including themselves, for new CIs. Okay, well, what about the students? Again, a smaller sample. But what do students who have worked with exceptional CIs have to say about their learning during those clinical experiences? And I like this image as a metaphor for the extreme importance of the support and scaffolding, that is the ropes and the partnering and the guidance that CIs provide as students begin to try their wings. And that's our youngest son. He's over in Norway right now, rappelling, and probably as we speak, oh, a little too dark over there yet. They're losing their daylight very quickly. So, students, when we asked them for an exemplar, all 8 of our participants had difficulty with this question and stated that it was not one single event or experience that stood out for them. Rather, it was what one student put as all the little things right from the start. And examples of those little things that came up frequently are shown here. The positive use of questioning, mutual brainstorming about ideas for patients, the CI serving as a guide to resources for addressing questions, and the CI's enthusiasm and patience when working with the student and their clients. 7 of these 8 students felt that their CI's teaching philosophy or teaching style was one that involved the fostering of discovery learning by asking questions of the student versus teaching through telling. So you can start to hear the resonance with what the CIs were saying. It's important to note that none of the students reported that they felt threatened by the use of questioning by their CI. Because we all know that the form, the function, and the timing of questioning can have a huge influence on the way that we emotionally and cognitively will respond to those questions. In medical education, in fact, the pervasive use of questioning in medical education, and we see it on television all the time, or we experience it and when we're out in the clinic, is actually called pimping. That's the way it's referred to in the literature, not just by me, all right? And at its very worst, it's referred to in the literature as malignant pimping. Very biomedical and probably quite appropriate. And fortunately, medical education is looking at this and trying to change the culture of medical education because of this realization. And so I'm on several medical education listservs, and I'm very, very pleased with the work that they're doing in that area. Instead, the students in this population, in this sample, viewed the questions that the CIs were asking of them as a way of inviting them into the conversation, of valuing their opinion and their knowledge. And so that's really important, and that's why we need that detailed microethnographic data, because we can't really understand how that's so different from one to another until we look at much more detailed videographic analysis of their interactions. Many students also felt that the CI's philosophy involved tailoring their teaching to the students' needs. The specific teaching techniques or strategies that these students described their CIs using to enact their philosophy included first and foremost a planned sequence of learning through seeing, feeling, and then doing. And most often first with the CI and then with the patient. Others identified the use of focused homework assignments and encouraging the student to come back with information or encouraging their opinion or input for clinical decision making. Also, regularly scheduled times for mutual assessment of learning as well as CI teaching. So these were usually weekly meetings where they would sort of replay the week and then reflect on what was learned and where they needed to go next, including the CI's teaching. When the students were asked to describe characteristics and attributes of their CIs, there were 3 ways of being that were identified in this sample. They were respectful in their interactions with the student and others, they were interested in and receptive to the student's ideas, and they were accessible and approachable. And the last of these descriptors is really important because Deb Selheim has pointed out in her studies of classroom teaching and physical therapy that an instructor can be very available and very accessible and not at all approachable. And so the key here was that the students felt respected and important. For these students, as we might expect, the CI's ways of being spilled over into their ways of doing or teaching behaviors. In fact, what we can see throughout these descriptions is that in the view of the students, the CI's teaching philosophy, their teaching behaviors, and their personal and professional characteristics all merge, and the distinctions between those things are really hard to grasp. So the most frequently cited teaching behavior then was that treating the student with respect and as a colleague. And again, this is where I think a lot of our social linguistic data will really help us to see how that's actually enacted, and certainly the modeling. When discussing the type and level of supervision provided by their CIs, the students described this kind of gradual shifting from direct to indirect supervision, shifting of responsibility for task completion from the CI to the student over time. And this is captured, this is a model that's adapted from some in educational research literature to show this shifting of responsibility. It's important to notice that the dynamic assessment, the diagnosis of readiness that Scully and Shepard talked about is really critical. And one student in the sample just described this whole process as having sort of 2 prongs. They said their CI always asked me when I was ready, and if I was ready, and then he just knew when to let go. So this hardly captures that in the decision making that goes on around that. When the students in this sample described the most challenging situations, there were 3 primary categories that they encountered during their clinical experiences. And in all cases, they saw they're working their way through these experiences really. They were very much helped by their clinical instructors. In fact, when we looked at this in analysis, we felt that some of these moments were actually exemplars for the students that they didn't report out earlier. So they recalled difficulties when they were dealing with patients with communication barriers, with really complicated psychosocial and multi-layered problems, including aggression toward the student. And then when they encountered legal and ethical issues, including potential neglect and abuse, overutilization of the student, and then trying to ensure adequate supervision and utilization of services and reimbursement issues. So those are some of the things. We wanted to know what the students felt the CI's take-home messages were for them. So these resonate with the things that the CIs wanted the students to take home with them. First and foremost, the strongest message that the students reported is that they always learned that they should keep on learning. That was the loudest and clearest. They also felt that they should be involved as a professional in their field, be respectful and compassionate toward patients and caregivers and others, and try to see the whole picture with all of their patients. So here are some concluding thoughts. The CIs that we've talked about today truly enjoy their work with students. And as one CI stated, it keeps me fresh, it keeps me alive. Many of the findings of this study bear resemblance to those of Scully and Shepard, and Jensen and colleagues' work with PT clinical experts, and the work of Irby with exceptional medical educators. These CIs also espouse, and I believe many embody, many of the core values and virtues that are described in the APTA professionalism document. So this is very good news. Furthermore, these CIs, I believe, are engaged in regular inquiry into their own teaching, from vision through design, through enactment, and through assessment of outcomes. So they're constantly remaking themselves as teachers. And I'm simply a collaborator in that essential phase of making the act of clinical teaching and its influence on learning into a public one, which Lee Schulman and the Carnegie colleagues say is what creates it into truly a scholarship of teaching. These CIs, the other good news is that these students want to emulate their CIs in their future work with students. So they want to be like those CIs. And so the admonitions to pass it on or don't break the chain carry with them the promise for future students and developing professionals to be like them. We do need more data and analysis to create a clearer and more elaborated picture of mastery in clinical education, obviously. This is just the tip of the proverbial iceberg. And it's clear that the voices of CIs and students alone, and out of the context of the actual clinical experience, though important, are only small pieces of the puzzle. And so hence the need for moving forward into phase 3 and 4 of the study. So where do we go from here? To achieve the broad purposes of the study, it's critically important to hear the voices of others, including patients, and so they'll become part of the sample in the future. We need to better understand the culture of the clinics in which these experiences occur, and we need to look for congruence and dissonance between what is said is being done and what is actually being done. So we cannot do that until we have the actual observational and videographic data and do the microethnographic analyses. Finally, much of the data that I presented today is obviously shaped by the questions that we asked. Though they were open-ended and it was a semi-structured interview, the data is shaped by the questions we asked. In the future, the questions we ask should be shaped by our observations and the things that we see in the more detailed analysis. And that should give us a much clearer and more elaborated view, a more contextual view of what's going on in clinical education and physical therapy. So I'd like to thank you for your patient attention on a Friday. And I'd welcome questions or comments. And this has nothing to do with clinical education, but it's Fox Glacier and Mount Cook on the South Island of New Zealand. So.
Thank you, Dr. Mostrom. If there are questions from the audience, please remember to use the microphones. As moderator, I will take the moderator's privilege to start us off with a question.
Do that.
I was surprised to hear that some of these good clinical teachers were so young. You cited a couple that had only been out of practice for a couple of years.
Right.
Do you have any additional thoughts as to how a person so young in their professional career would become so skilled?
Well, the ones, if we do an analysis and look more at some of those that were the younger group, if I separated them out in that total CI sample, they reported really positive experiences in their academic preparation early on, that they had somebody that they really held up as a model of professional engagement. They had really positive experiences as a student. And so they really wanted to do that more. They were also, like all of the sample, but I think just tremendously engaged in the profession earlier in their career, and very, very energetic. I don't know that they have different characteristics than some of the others, but they were just so excited to get involved in clinical education that as soon as they could, they did. And they ended up being nominated for these awards and actually receiving the awards. I don't know if that helps or not. You might think, and a lot of times I think a lot of our students think that I want to have an experienced supervisor, but I don't want them to be too experienced because they'll forget what it was like to be a student. But in this sample, what we saw is the clinical instructors who were recipients of the award did not forget what it was like to be a student. They carried that identity, even if it was 20, and in some cases 30 years ago. They still remembered critical experiences from when they were a student. And again, some of them told them what they wanted to be as a clinical teacher, and some of them told them what they didn't want to be as a clinical teacher.
Thank you.
I saw is people nodding off.
Can you hear me? One question. How do you see your data supporting educating and preparing clinical instructors for the future?
Well, I would like to think it's been presented in a couple of forms as the study has gone on, and there are other colleagues in the country that are doing somewhat similar research. We do want to move that next phase I mentioned into a much larger scale study that is similar, and you may not be familiar with it, but physical therapist audience would, the work of Jensen and their colleagues on expertise in physical therapy practice. And what I'd like to see, honestly, is a book about expertise in clinical education in physical therapy. And I'm trying to gather together some colleagues around the country that we could do that. So what the next proposal that goes in for that next phase will be like that. In the meantime, I hope at the APTA, we've developed the CI credentialing program, and they're moving now to develop a sort of step 2 of the CI credentialing program. And I would like to see my findings considered when they develop curricula for those different training programs for clinical educators around the country. And I think there are a lot of other people that are doing work that will inform the curricula as well as the types of learning experiences that are built into those training programs. And Alex is one of the CI credentialing trainers. And so, but I know several people that are working on that project, so I hope that in that way it gets out more and more to clinical educators.
As someone who's been on the faculty for the Train the Trainer course also, I hope they do regard your findings, because I think what your data shows is going to be very helpful to the development of the curriculum for the second phase of the APTA CI credentialing
I hope
course.
so.
Yeah. My question is about contrasting and comparing the literature that is describing the novice to expert progression. Both Patricia Brenner and Dr. Jensen's work describes that. And I'm wondering if you have any thoughts about the progression of teaching excellence and whether or not the expertise in clinical work parallels that at all.
I suspect that it does, but I haven't really separated things out into novice or expert and look for differences, or novice or more experienced in the data set that I have right now. I could do that, through sort of sampling within my thing, but I would need probably a few more novice clinicians, clinical instructors to help with that. So the original study design didn't provide for that, but that's a really fascinating question. And so it might build on what Peter had talked about earlier if we specifically targeted a sample of brand new clinical teachers and a sample of more experienced teachers, and not necessarily those that have been identified as outstanding or anything like that, just a sample of clinical teachers. I know that somebody at University of Indianapolis has expressed to me and talked with me about having an interest in doing a study like that, and she wants to use qualitative methods, and that's why she consulted with me, but I'm not sure where she is right now in the design and implementation of that study. So. Thank you.
I'd like to say thank you, Dr. Mostrom.
Oh, there you are.
Very much appreciate we appreciate your presentation. It was
Okay.
It was great. Thanks.
Thanks. Thank you.